press the red button, is it? Thank you very much for the invitation to come to this conference today. I'm delighted to represent OCHAR, the out-of-hospital cardiac arrest register. Many of you would know of Siobhan Masterson, who has been the manager of OCHAR up until very recently, and I've just taken over from her. She's moved on to do a PhD on this very topic, so delighted to be here. As we've heard several times today, data collection, registers, etc. are extremely important, and I strongly believe in that as well. Personally, I have a personal interest in this area as well. Cardiac first responders, very close to my heart. We owe our father's life to the likes of yourselves. He's a 10-year survivor, happily living in Denmark. And what's more amazing probably is that cardiac first responder, he had resuscitated 2 other people in his life before then, and he wasn't even part of an organized scheme like yourselves. So it just shows you some people have the habit of being at the right place at the right time. So delighted to be here. So how did OCHAR arise? Well, there was first a provision in the report of the Task Force on Sudden Cardiac Death in 2006, which was published by the Department of Health. And in that it said that data collected on resuscitation in the pre-hospital and hospital settings can provide the basis for an information system to quantify the frequency and geographic spread of cardiac arrest and to support service planning. And I think you've seen many presentations already today that exactly has done that. So I think already OCHAR has proven its worth in that respect. We've talked about service planning using OCHAR. We've talked about research, etc. So OCHAR commenced in 2007 in the Northwest and has spread throughout the country to reach national coverage in 2012. So we have completed 2 full years of data set. We will soon have 2014. We're still collecting data, and we're now in the 4th year of data collection. And it's building up nicely. We have already now a repository for evaluation, service planning, and research. Who is involved in OCHAR? The HSC is hosting the register. It's funded by FEC and the National Ambulance Service, and NUIG also is involved in terms of academic and administrative support. So it has a strong support base, and I think this is really impressive. The people I've met since I started here are strong believers, fully behind this, and I think it's fantastic to see. Why would you want to have a register, an out-of-hospital cardiac register? Well, basically, the overall aim is to facilitate improved survival from out-of-hospital cardiac arrest. So we're looking at finding out what's the survival rate, what's also the incidence of out-of-hospital cardiac arrest, what are the factors that contribute to survival, and from that on follows then, well, what could we do different to improve survival? And now we also see that OCHAR data is used to provide regular feedback to service providers such as the National Ambulance Service. So we need to have a definition as to what is an OCHAR, which cases do we include in the register. So the precise definition is that it's all patients who suffer a witnessed or unwitnessed out-of-hospital cardiac arrest, which is confirmed and attended by the emergency services and resuscitation attempted. So if there's no resuscitation attempted at all, it doesn't go into the database. So that's the definition. So what's the mechanics of setting up this register? How do we get our data? Well, the main data source would be the unseen information collected. So the patient care reports that's completed at a scene by the emergency services and now increasingly by yourselves. That comes in via the National Ambulance, that's completed by the National Ambulance Service on scene, the Dublin Fire Brigade. And the cardiac arrest paperwork, the PCRs, the patient care reports, are prioritized because we want to to facilitate OCHAR. And that is through the One Life project that we have heard about earlier from Carl O'Donnell. And we have what's now called the so-called yellow envelopes, which ambulance personnel is asked to use when they've finished a call. They log, they put in the PCRs into the yellow envelopes, and that's prioritized and sent to OCHAR for the register. We then also get data from the ambulance control centres. And the moment we have a few of them, and as we've heard this year, we'll have just one centre, and they provide data on the nature of the calls, the times, etc. And then in terms of outcomes, OCHAR has data sharing agreements with practically all hospitals throughout Ireland. So there's a lot of different players involved in populating the OCHAR register. And this is an example of the out-of-hospital cardiac arrest page on the patient care report developed by FEC, which basically includes all the relevant data fields for the register. You yourselves will be familiar with your own form, and I suppose my main message here today is to emphasize to you how important it is to fill out the data as accurately and comprehensively as at all possible. You'll see the data that's been shown in various different contexts, but that data or that service evaluation, that research is only as robust as the data that goes into it. So you'll see, you've heard earlier today, what are the key factors. So if you're there first on the scene, was the collapse witnessed? Very important. Was there bystander CPR? What was the initial rhythm? And were shocks advised, and how many were delivered? So I suppose that's one of my key messages, accuracy and comprehensiveness, because it's not filled out, it's missing data. It could have been either way. So I hope I'll fly through this, because we've already seen this a few times, which is fantastic that people are actually using the data. Hopefully over the years then we'll begin to see trends, etc. But for now we have 2 years full data that we can show. You've seen this map, this is 2013. These are the full numbers of OCHARs in those respective years. About 60% happen in urban areas, but there's the same incidence of cardiac arrest in both rural and urban. So you're as likely to get one whether you live in rural or urban communities. So what was the rate of CPR if an arrest happened that wasn't witnessed by ambulance personnel? It was 60% in 2012, and it's gone up to 69% in 2013, which is a nice increase. Our data show that we have about 5 to 6% of people with an OCHAR that survive the discharge. But I would say there's a margin of error there, because there are actually some patients that are hard to get data from. So it's plus minus 1% either side. So it's roughly the same for the 2 years. We can't say, I think with certainty, there's any definitive increase there. So you've heard Dr. O'Donnell explain as well why it's important to look at a comparative subset, because of the different variation in etiology for why people actually get a cardiac arrest. So this is the so-called comparative subset for 2013. And you'll see that for adults that have a presumed cardiac reason behind their cardiac arrest, bystander witness and shockable, we have 308 cases. So that's our comparative set for 2013, which we can use to compare more or less with other countries and other groups, etc. We've seen what are the factors that will help improve survival, and I don't need to go through that, but the reason I'm showing that here is because I'm pulled out some of that data that is relevant to that. So for that comparative subset, the data we have for those 2 years, because we don't have full data quite, but almost full data, that bystander CPR was performed in that comparative subset, roughly 80% of cases for both years. again, for that comparative subset, about a quarter received a shock before the ambulance arrived. So that's likes of yourselves have delivered that shock. So that's gone up slightly from 2012 to 2013. Again, in the comparative subset, we have survival of around 23% in 2013. So that equates to that amount of patients that you see there. And about a third of these surviving patients were defibrillated before the ambulance arrived in the first place. So this is the kind of these kind of data is the ones that we hopefully with time, as the register develops and with initiatives like yourselves, we can begin to see maybe trends, we can begin to see things change over the years. We can't say one thing causes the other, but we can say with a cumulative effect between the different changes in the ambulance services, yourselves, etc., what does that do? So again, in terms of your contribution, with your patient care forms here, very important to fill them out accurately. If you know the times, I know it's an emergency situation, if you know the times, fill them in. Was it bystander witnessed? What was the rhythm, etc., etc. The more accurate and comprehensive data we have, the better our register. So I suppose all the people involved in this work together to basically improve both the quantity and the quality of the data so we can map the Irish OCHAR situation together. I think it's a credit to Ireland that they have a register. There's only, to my knowledge, 2 other national registers in Europe. Those countries have personal identifiers. They have a long history of registers. It's easier for those countries to develop a register such as this. It's difficult in Ireland. I think that shows it's fantastic that it's been set up. And just to give you a wider perspective, you're not only feeding into the Irish scene. There's a European study that is just gathering data, has just completed data collection in October 2014 that's going to look at data from 27 different countries all over Europe, and the data you've collected has gone into that study, and that's another development that's happening. So thank you very much.